This lecture will go over spinal shock versus neurogenic shock versus autonomic dysreflexia. First, we'll start with spinal shock. Spinal shock, also called spinal shock syndrome, occurs immediately as the cord's response to injury. The patient has complete but temporary loss of motor, sensory, reflex, and autonomic function that often lasts less than 48 hours but may continue for several weeks. Spinal shock is not the same as neurogenic shock. Neurogenic shock is a type of distributed shock. The trauma causes the loss of sympathetic stimulation. And if you go back to remember what the sympathetic nervous system does, that's our fight or flight, right? So the loss of sympathetic stimulation would result in bradycardia and hypotension. This may occur within hours of injury and is most commonly occurs in patients with an injury above T6. In our patients at risk for neurogenic shock, we want to monitor hourly for SPO less than 95% or symptoms of aspiration. Monitor hourly for symptomatic bradycardia, including reduced level of consciousness and decreased urine output. And monitor hourly for hypotension with systolic blood pressure less than 90 or mean arterial pressure less than 65. Notify the provider immediately if these symptoms occur because this problem is an emergency. Treatment for these problems that occur with a neurogenic shock, if the patient has respiratory compromise from aspiration, they may end up being intubated or may have a bronchial endoscopy performed. If the patient is experiencing symptomatic bradycardia, atropine may be prescribed if the heart rate is less than 50 to 60 beats per minute and the patient is symptomatic. If the patient is experiencing hypotension, dextran, a plasma expander, may be used to increase capillary blood flow within the spinal cord and prevent or treat hypotension. And dopamine might also be ordered. Hypotension, if severe, is treated with continuous IV sympathomimetic agents such as dopamine or other vasoactive agents. Now we'll discuss autonomic dysreflexia. Autonomic dysreflexia is a potentially life-threatening condition in which noxious, visceral, or cutaneous stimuli cause a sudden, massive, uninhibited reflex sympathetic discharge in people with high-level spinal cord injury. Typically, the causes of autonomic dysreflexia are gastrointestinal, gynecologic, urologic, or vascular stimulation. Some example of causes include bladder distension, UTI, scrotal compression, bowel distension or impaction from constipation, irritation from hemorrhoids, pain, tight clothing, and temperature fluctuations. Signs and symptoms of autonomic dysreflexia include a sudden significant rise in blood pressure accompanied by bradycardia, profuse sweating above the level of lesion, flushing above the level of lesion with pale skin below the level of the lesion, goosebumps above and possibly below the level of the lesion, vision issues such as blurred vision or spots in the patient's visual field, nasal congestion, onset of a severe throbbing headache, and a feeling of apprehension. The severely elevated blood pressure can cause a hemorrhagic stroke. Care for the patient with autonomic dysreflexia. First priority is to place the patient in an upright seated position. Raising the head of the bed helps to immediately reduce blood pressure. Assess the bladder, bowel, skin, clothing, and temperature. So if the patient does not have a catheter, you could assess for bladder distension. If that may be the cause for the autonomic dysreflexia, we could get an order for a straight cath to relieve that bladder distension. If the patient has an indwelling catheter in, we might want to check it for kinks or anything that may be preventing it from draining properly. Want to check the room temperature and bed coverings and adjust the patient as needed for comfort. We could assess the skin and also look at the patient's history of bowel movements. So is there a chance that the patient is constipated or has an impaction? Basically, what we want to do is get the patient seated upright and then figure out what the cause is for the autonomic dysreflexia and address that cause. We want to monitor a patient's blood pressure every 10 to 15 minutes and give medications as prescribed to lower the blood pressure.